Good morning. Thank you, Omar. And Mr. Chairman, dear panelists, and my dear colleagues, ladies and gentlemen, I would like to thank the organizing committee to invite me to present the topic, Considering Device and Technical Issue. I'm Jieh-Neng Wang from National Cheng University, Tainan, Taiwan. I have nothing to disclose. Transcatheter PDA closure is now a center of care in most cases. However, its technical challenge still in premature baby because anatomy problem, PDA tubular type, and small dimension of the descending aorta, physiologic problem, PDA might get spasm, sedation problem, contrast-induced nephropathy, and difficulty in device selection. Some devices are too bulky or too floppy, no optional device, vascular access, artery or vein, transport to the cath lab, or we can do it on the bedside, radiation exposure or by echo guide, and how small is small. Before discussing the device issue, we need to first understand to refresh the morphology of the PDA. We traditionally using the Cheng classification and the type A, B, C, D, E. However, in the 2016, Dr. Phillips and his team find that the premature baby, there's a long and wide tortuous PDA, like we so-called the type F PDA. This is a small baby or the 1,400 gram baby. You can see that it's a very tiny baby, but very small, very big ductus, and it's large and it's tubular type. And you can see there's a 1,300 gram baby, and you can see that's a very tortuous and very long. So anatomy is similar, like a fistula, no ampulla to deploy the retention disc. Therefore, my colleague, Dr. Cheng summarized in his experience and summarized the introductory displacement. You can see that when the device was in place, the PDA, when after constriction follow up, the PDA will going like this and no harm for the LPA or coarctation. But if the device is too long, you can see after the follow-up, you can see that it may cause LPA or coarctation. So that's why we favoring a shorter device recently. Current commercially available device, and we often use coil and AD01, AD02 for the PDA closure, but in the premature baby, it's not suitable. And vascular plug 1, vascular plug 2, and piccolo device was more common. And we have the new device and the microvascular plug like this, and micro plug set like this, and vascular plug 4 may be useful in some cases. However, in recent review, showing that only the piccolo device were confirmed, was approved by the CE and the FDA, were approved on over baby larger than 700 gram baby, and it has many 3, 4, 5 waist diameter, and the device length was 3, 2, 4, 6. So you can many kinds of choice you can use it. And off-label use is a vascular plug 2 device, but it's too long because the length is relatively fixed. So it's probably too long and may cause the LPA or coarctation. And the vascular plug 4 was also the same problem. And the Medtronic and the MVP device may be too long. And the micro plug, we have limited experience on this. And you can see that the picture of the piccolo device, you can see there's a 2, 4, 6 long, and 3, 4, 5 wide. So you can 9 kinds of device. You can use it on very situation. And the vascular plug 2, because the length was fixed, the relative fixed, although he has many of the diameter, but it might cause the LPA or coarctation, and vascular plug 1 also have the same problem. You can see before with the intervention, we need to first to see the PDA type and size and the length. And Dr. Pardo compared the measure the PDA using the angel or echo. And you can see that actually the PDA is like a hockey type. The length is like this. But if you measure on the echo directly, you might underestimate the PDA length. So you can, if you have that's like a Matsubara, Dr. Matsubara, and you can use in the PDA, the type is a 3-dimensional. So if you can use a 3D printing for the PDA, you can test it on the device, it could be better. But we know that currently it's not possible for the premature baby. And the most important, I would like to say, Dr. McMara, and you can see that the doctors maybe look like this, very straight, or very serpentine, or very short, or very watery skin, or narrow, or the shape. And you can very cautiously to using the viewing the 3D structure on the 2D. When you measure like this, you can see many difference of the PDA wide. So, and another problem, PDA might get spasm during the angel. It's not a premature baby, but you can see that before the intervention, it's 6 millimeter. But after when I put the cath lab, you can see that angel, my gut spasm, so I underestimate the PDA size. So in my personal experience, I was more reliable for the echo on the PDA sizing. And in the limited resource area, you can use in the traditional to do the vascular access. You can see the transilluminator to see the vein, femoral vein clearly in the tiny baby, and using the strap, and using the IC catheter, and over the wire technique, and you insert the sheath on it. If you have the budget, I would strongly recommend for the Echo Guide. Echo Guide, you can see using the Echo Guide machine, and you can 500-gram baby. The femoral vein diameter was 1.3 millimeter. You can accommodate this 4-French sheath. And if the preparation is a 4-French sheath, insert on 500-gram baby, and if you can use an umbilical vein, you can even do the baby on 478-gram baby. But just do not try the artery approach. But there's some tricks for using the umbilical vein approach, because umbilical vein was from the surface on here, so you need to bend in. Inducer sheath the tips might be slightly bent and to insert to pass through the angle of ductal venous and IVC. That's the why, and this is a traditional femoral vein approach. And there's very variability, different approach method. And somebody will prefer using the balloon catheter to insert the wire. Some will prefer just using the woolly wire. But our approach is wire, using the tiny wire going first. As far as possible, catheter manipulation is within the cardiac chamber are avoided. You can see that using when the baby larger than 1,000 grams, I'm using the 0.025 terumo wire, and the wire can go to the PDA, and catheter could follow. And using this is umbilical approach, and when the baby is smaller than 1,000 gram baby, I'm using the 0.014 coin wire. It's a tiny wire. You can see the follow, and it's just careful manipulation, and you can go to the PA, then go to the PDA. Then catheter could follow. When the catheter could follow, then you can hand injection, the contrast injection, to make sure the PDA length and PDA size. And I will exchange the 0.035 wire for the exchange to deliver the delivery sheath. And avoid the heparin bolus administration is my experience. If you don't do it, just using the tiny wire to insert the delivery sheath, you might have the problem of the wire catheter mismatch. You can see that it's not easy, the wire catheter mismatch to go into the PDA. And once the delivery sheath was in place, you can deploy the device and deploy the device. It's a 5-4 device. You can see that. And in this case, you can see when I deploy initially, looks fine, but after, you can see when I prepare to deploy the device, but you be very careful to see the shape of the device. You can see the LED disc a little bit protruding. So I think immediately it could be the device is too big. So I retrieve it and using the smaller device. You can see the 4.4 device. This could be better. Then you can check the echo. Check the echo. You can see the LPA, RPA. There's no obstruction and no coarctation. Immediately you can check it. And if you have the concern because some patients have no urine because of the drugs, and the 500-gram baby, no contrast, no more contrast use. You can use echo monitor only to deploy the device. I have the case, you can 500-gram baby, and is a 4.1 millimeter. It's a very large ductus. So I think in the early experience, I think the Piccolo device, the 5 device might be too small. So I use the vascular plug 2, the 6x6 device. After the deployment, the condition is well. And after the follow-up 3 months later, the chest X-ray and symptom improving and no cardiomegaly. And this is a 1,400-gram baby. You can see that it's a tubular. The PDA size of 5.3 millimeter and it's 4.3. And so initially I using the vascular plug 6x6, but it doesn't work to accrue the PDA. So therefore I change to the bigger device, plug 2 8x7. You can see the very big ductus and and deploy the device. It seems fine. And I check the PA angle to see is there any PA obstruction. But when you can see that the device shape is a little bit protruding. When you can compare when I first deploy it, you can see, but the device is slipped into the maybe the coarctation. So I change to the vascular plug 1. Vascular plug 1, you can see that after the deployment, the PA and the coordinate, there's no coarctation. So that's why I change the device to the plug 1. You can count Dr. Becker's in his experience, the complication of the plug 2 because it's too long may cause LPA and coarctation. Therefore, it's very important, because we are recent years experience in the patient smaller than 2 kilograms using the intraductal displacement, and if the ductus length was below 12 millimeter, we use the smaller device, the length is 2, and the diameter is like this. You can use the 5 2 device, 4 2 device. But if the length is larger than 12, you can use in the 4 device, 3 4, 4 4, or 5 4 device. But in the larger baby, because the strong hemodynamic, you can use in the longer device. LPA hypoplasia and LP obstruction is a concern. And in my patient, in the 500-gram baby, before the intervention, you can see that the PA size is fine. But after 1 week's follow-up, you can see that there's obstruction, LPA, the turbulence flow. And 6 months later, you can see that even there's no obvious obstruction, but the LPA is a little bit hypoplastic. And follow-up, the 1 year follow-up angio, you can CT scan, you can see that LPA a little bit obstructed, but 6 years later, luckily, you can see that the LPA was fine, and there's a pressure gradient was 7 millimeter. Patient has no symptom. This is my worst cases. A 600-gram baby, and the PDA size 2.9 millimeter at that time, in the 46 hours because of acute pulmonary hemorrhage. So we brought it to the cath lab for the intervention. And initially I used the 4.4 device, but we cannot accrue the PDA have the significant shunt. So after we changed to the 5.4 device, 24 hours later, you can see that the clinical condition seems improved. 48 hours seems improved. But after the day 0, you can see that it seems fine, but 2 days later, there's obstruction in the gradient is fine. So initially, I think it's probably fine, but 18 days later, you can see there's a significant obstruction. So I have to ask the surgeon to remove the device at 5 months old. That's why we summarize the factor related to the adverse effect. According to the literature, it had smaller baby, younger, and the younger baby have the more possibility of the adverse effect. And our experience also showing that the age of the intervention is the younger, smaller than 9 days, and the body weight smaller than 700 grams, it could have the more possibility of adverse effect. Backside intervention, I think the next speaker, Cheng, has more experience than me, but I would like to show you the further we are doing is a 20 to 25 day baby. You can see that 303 is not a premature baby, but he has the PPHN after ECMO, CVVH, and the IVH, pulmonary hemorrhage, and pneumothorax. You can see the lungs, it looks like this. You can see under the jet ventilator, the patient still cyanotic and the very large shunt. And you can see the significant and the high ventilator, high frequency ventilator pressure setting was very high. So what's the condition? So we're using the echo, bedside echo guide, pure echo. You can see like catheter in the IVC, then wire going first, then wire going to the right atrium. You can see the wire here. Wire going to the right ventricle. Then wire smoothly going to the RVOT, and wire going to the PDA. And you confirm that the catheter could follow, and confirm that in the catheter in the descending aorta here. And open the left disc. Open the left disc, and that disc you can see that here. Then pull back into the PDA, and disc fully open and follow up. Then there's no PA obstruction. There's no coarctation, and the hemodynamic you can see that before the intervention is a very tachycardia, 190 heart rate. And the blood pressure was a little bit low, but after 10 minutes after the intervention, you can see the heart rate was improving and the blood pressure increased. After 1 day, the chest X-ray improved. So, sorry. In conclusion, our data showing that transcatheter PDA closure in premature baby is technically feasible and can be potentially with improved lung function. And current device could deal with the most of the PDA cases in premature baby. And step by step, following the intraductal placement might avoid the complication. But we think further study of multi-center to report the short-term and long-term outcome to based on the scale and optimize timing for the procedure. And finally, I would like to send to Korea, and I just remember when the 1999, when I was to join the third International 6-Day Symposium, I think I learned a lot. That's why I'm grateful to the Korean to organize this symposium. I think it's very good. All my participants, they all have the very good achievement. I would like to thanks for the team and thanks for your attention. Thank you.